Hi there, welcome back to this final part of this masterclass series on thromboembolic diseases. In this talk, we'll be talking about thrombophilia, and in order to focus on the case, you may well have needed to see the last two masterclasses, so if you haven't, I would go back to them. I'm Russell O'Brien, I'm a consultant in acute medicine at the RD&E Hospital in Exeter. In the previous case, the previous masterclass, we had a case regarding a pregnant lady called Lauren who really wasn't having much luck. She'd had clinical symptoms to suggest a DVT, a pulmonary embolism, and then later on in pregnancy developed a venous sinus thrombosis. So when these kind of things happen, you have to sort of say, is this just bad luck? You know, what's going on with this woman? She's had two or three things. Is it just pregnancy? And it may well be. You know, all of these have just happened in pregnancy. But if you went back to the case as well, you would see that she'd had a number of miscarriages as well. And whilst that may sound unrelated, sometimes there can be an association with recurrent miscarriages and a prothrombotic state. So we could start to conclude that maybe she's got an acquired clotting thingamajig, some kind of problem over and above pregnancy, and it's just been unmasked during pregnancy. Is it something in her genes, or has she got some kind of DIC picture? Well, you could ask all of these kind of questions, but it's certainly reasonable at this state to conclude that she might have a thrombophilic state. This could all be pregnancy, but it could be something that's actually genetic that she's been born with, or perhaps some other reason other than pregnancy that she's acquired a prothrombotic state. So they are roughly the two divisions. Is this something that's entirely defined by the genes? And often there will be a family history then of multiple pulmonary emboli or DVTs, or people who've died of those, or other similar issues. But occasionally it can just be acquired. If you look at this picture, you probably don't know where it is from just looking at it. The canal gives you a bit of a clue, and this is actually Leiden in the Netherlands. And the reason I'm putting this up is that there is a very common gene abnormality called factor V Leiden mutation. If you cast your minds back to the first masterclass, we talked about some antithrombotic proteins that actually work to counterbalance the risk of thrombosis, and one of these was called protein C. And people with this mutation in factor V have a resistance of their factor V to this antithrombotic protein C. So if we just remind ourselves of what these were, you can see over on the right that activated protein C would have an effect on active factor V, and that is not as potent in patients with this genetic mutation. It's pretty common worldwide, but it's particularly common in the UK. So this is a very everyday reason why somebody might be more prone genetically to have venous thromboembolism. Obviously, there's not a lot you can really do about it, and if you're born with this, then this is a sort of tendency. So it's often that we don't end up checking this, but certainly in people with recurrent venous thromboembolisms or arterial thromboemboli, we start to think, is it worth looking into some of these kind of conditions? There's a large number of these, and they're certainly way beyond the scope of an undergraduate talk, and certainly, they're not something you need to spend an awful lot of time looking at. But here's just some named conditions, both congenital and acquired, that you will hear banded around when we're talking about people who've had recurrent arterial or venous thromboemboli. So we've mentioned factor V Leiden mutation. That's certainly one of the most common. There are also mutations in prothrombin and deficiencies of both protein C and protein S in themselves. Antithrombin deficiency also exists. One of the most common ones that are mentioned or certainly investigated for is something called antiphospholipid syndrome, which we'll briefly come back on the next slide, and also myeloproliferative disorders as well, which we'll touch on briefly before the end. I stress that you would probably be not wasting your time as an undergraduate, but certainly knowing, spending too long on the individual aspects of these is probably not necessary at undergraduate level. It's quite a specialist area, but just being aware in patients who've had recurrent problems, this is what you might start to consider. So, for instance, that's antiphospholipid syndrome. People have both venous and arterial thromboemboli. There's also possibly a history in female patients with this, that they have recurrent miscarriages, or maybe their mothers, aunts, and other people in the family have as well. And it's marked by a presence of an antibody that increases the risk, and there's something called lupus anticoagulant and anticardiolipin, and these can be tested for to see if somebody's got antiphospholipid syndrome. The final thing I'm just going to mention before concluding this very brief overview of conditions that lead to a thrombophilic or a prothrombotic state are the myeloproliferative disorders. Again, well beyond the scope of this individual talk, and please, don't spend too long individually on these, but you will see patients with each of these conditions in clinical practice, and all of them will have an increased risk of thromboembolism. So the myeloproliferative disorders are polycythemia rubra vera, sometimes known as that, primary myelofibrosis, essential thrombocythemia, and CML, a chronic myeloid leukemia. And so this is an expansion of that myeloid cell line. So these people will have high hemoglobins, they'll be thrombocythemic, and obviously have signs perhaps that the rest of the marrow isn't so healthy. Underpinning this, there's often common mutations in trigger genes. One of those is called JAK2, and sometimes these patients will have arterial venous thrombosis even before the underlying hematological condition has become apparent. Certainly I have a friend who had a parent who had primary myelofibrosis, I think, who presented with a dural sinus thrombosis, and it was noted that their platelet count was a little bit high, and they went on and been investigated, particularly because of that family history, for a myeloproliferative disorder, albeit at an early stage. So again, this is quite a specialist area. It's very much the remit of the hematologists, but it's worth considering whether or not you would speak for hematological advice in patients who have unprovoked VTEs or arterial disease or atypical patterns of thrombosis. Because every now and again, somebody will have one of these underlying conditions, and certainly it sometimes alters management, even if it's just higher levels of anticoagulation as well. Okay, so this is just a couple of slides finishing off this series. In summary, over the masterclasses, we've reviewed hemostasis and its relevance to thromboembolic disease. We've touched on both arterial and venous thromboemboli, and we've gone through bit by bit each stage of Virchow's triad, looking at cases that hopefully just push you a little bit further on from just a standard DVT or a pulmonary embolism. And in this talk, we've just touched on thrombophilias and the complexity of investigation as well. Some other topics to look forward to if you want to go a little bit further in this area. A few of the things we haven't touched on at all include something called a post-thrombotic syndrome. So somebody's had a very large DVT, what that does to the leg. Similarly, people who've had large pulmonary emboli can develop pulmonary hypertension. You could look into other forms of thrombosis like portal vein thrombosis and the Budd-Chiari syndrome. And what we haven't touched on really in any shape or form, but is very much every day as far as you're concerned as a junior doctor to be, is the common antiplatelet and anticoagulant drugs. And that will be the next masterclass in this series, so look out for that. Anyway, thanks for your attention. I hope this has been useful and informative. Thank you.